So we got a couple of things that we need to talk about on lateral, some variations of lateral. And we may do these if the patient's had surgery or if the patient's got scoliosis or if they're just not showing a whole lot of mobility, if they've shown a loss of mobility. So we have two different things. One is just like what we saw in the C-spine, that was flexion extension. But we've got another one too, and that's lateral bending. All right, so these may be the only true two-view L-spines that you get. So what they don't involve is any kind of AP for the flexion extension. Now, I want to show you something real quick though, is this. All right, so you got to understand that whenever we do, when you bend, you've got a lot of vertebra. So you got a lot of zygohypophyseal joints. And the mobility in your spine doesn't come from one area within the spine being, relatively mobile, right? Where's most of that rotation, most of this coming from? Hips, exactly. It's the hips. So we'll do flexion extension. You're going to see this. People say bend over and touch your toes, and you will get the bending that you're looking for in the vertebra. But most of that has nothing to do with the vertebra itself. That's about as far as I can go without involving my hips, right? So theoretically, you could tell your patients because in a lot of cases you tell somebody to bend over and touch their toes, and they'll keep their back pretty straight. So what you need to be is very specific in your instructions with the patient. You can tell them to bend over and touch their toes, but tell them to arch their back when doing so, right? To make sure that you get the mobility, the true representation of mobility. But in this L-spine, that's what we're going to do. Flexion extension is something similar to this. Again, you could probably get a better study just by telling the patient I want you to slouch as far as you can. All right, instead of bend over and touch your toes, because most of that's coming from the hips. So flexion and extension, what we're looking for on flexion and extension is not just mobility. Come out of that, magnify this up. But when we do a spinal fusion, I told you last week, what they'll do sometimes is they'll take a bone plug and they'll put it inside of the vertebra, and you might have a plate that goes over the front of it. Right, so they take the disc out, they put the bone plug in, they might put some screws and plates on it to hold it in place, or a cage inside of there that they'll put bone fragments in. And what the body will do is it will, since we've got two things that are full of calcium, it will hopefully make those two things grow together and fuse those vertebrae. So it's really not a big deal to fuse a couple of vertebrae. 2, 3 vertebra. Most of your motion is going to come, at the top in your rotation. It's going to be C1 and C2. Most of your bending is actually going to come from your hips. You're going to lose some mobility in the vertebra that are fused together, but for the most part, most of your rotation and everything else is because you have a lot of them, right? So just between the T-spine and the L-spine, you got 17 that are causing you to be able to rotate by, as much as you can rotate or bend or flex or whatever. So the patient's not going to lose a whole lot of mobility. So that's not really what they're looking for in flexion extension or lateral bending. What they're looking for in those cases, if they're not looking for actual mobility, what they're looking for is how well is that fusion taking place? Are the bones growing together? Is the bone plug growing to the vertebra above and below? Or when they flex and extend, can we still see a gap in between the two, indicating that you've got non-fusion of those bones? Okay, so that's one reason we would do flexion and extension. The other thing that we do is what we refer to as lateral bending. And in this case, you're not going to have any kind of lateral projection. The lateral bending is going to be an AP projection. The patient's going to just go to one side, make your exposure, go to the other side, make an exposure. Also for mobility, sometimes because the patient has scoliosis. if they've got some moderate scoliosis, they may not be able to bend quite so far in one direction as opposed to the other. Okay, so in both cases are for mobility. Flexion and extension tends to be for spinal fusions post-op. Lateral bending can be as well, but it can also be for scoliosis series. Okay. So then we've got a lateral L5S1. So again, if you have a patient who has a little bitty waist and they've got broad hips, then you may have density differences that make it difficult to see through L5S1. So what we'll do then is to take a collimated image just of L5 and S1. And the easiest positioning for this, it'll go right through L5S1. You can collimate down to just a entrance area of about, what would that be, 3 by 3? Beautiful image. But that is kind of like the swimmers for a C-spine. It's not automatic that you would shoot that. It would only be if the density, the radiographic density was so low at L5S1 that you needed it, right? It's an accessory view. It's not a required view on all patients. Rare on men. Most of the time it's going to be on very thin women with broad hips. Right? So it looks like that. And I just showed you this completely backwards. Standing up here, it's hard to on a skeleton, it's hard to do this. All right, so I went this way. It's actually the opposite direction. So you press the I don't know, you call it the knife hand of your knife ridge of your hand right above the iliac crest and fold it down that way, angle your central ray. Okay, can you see that back there? Okay. That's your L5S1 spot. Most of the time I just call it a spot. Your images come up, and if the text says you need a spot, that's what they're referring. All right, so obliques of the L-spine, bilateral obliques, again, can be done AP or PA. Most of the time you're going to do them AP because that's just uncomfortable getting on the stomach. So you'll see sometimes in some textbooks and some of your test questions will indicate that the degree of obliquity is going to be determined by where the patient's pain is, right? So what was your degree of obliquity for the T-spine?
For T-spine?
70. Yeah, it's 70, so it's very steep. So your spine doesn't go just, C-spine, blam, T-spine, shazam, L-spine. There's a slow curve from one end to the other. So naturally, if you're looking at the upper portion of the L-spine, you might need a steeper angulation than what you would at the lower portion. So if you happen to read that in a textbook or in a, DeAngelis or, some registry review book, that's what it's referring to. I think Merrill's just comes down with 45 degrees. So 45-degree angulation. The positioning is going to be similar to the AP, and that would be either at the iliac crest or inch and a half above the iliac crest. The positioning is the central ray is, I want you to notice, this is our ASIS, right? Anterior superior iliac spine. And on the AP, they should be symmetric. But as I rotate up, what's happening to the elevated ASIS in relationship to my spine, what's happening? It's getting closer and closer, right? So at 45 degrees, it's not going to be on top of it, but it might be pretty close to what would be the spinous processes. So if you find the ASIS and go about 2 inches medial to that, you're going to find the middle of the L-spine. Okay? All right, so 45-degree oblique, either at the iliac crest or inch and a half above, depending on if you want the lumbar spine or the lumbosacral spine. And then just anterior to the elevated side, ASIS is going to be your, central ray location. All right. So now let's roll back up to see what it is that we're looking for on each one of these. So on the C-spine and T-spine, we established that what we see in the foramina or the zygapophyseal joint is going to be exactly opposite, right? So for your lateral zygapophyseal, we're going to see zygapophyseal joint on the C-spine on the lateral, and on the obliques, it's going to be on the lateral. We're going to see the intervertebral foramina. But then, whether we see on the upside or downside for the opposite anatomy is going to be the same. So the AP axial, we're going to see the foramina on the upside on the C-spine, foramina on the downside on the PA axial. T-spine is going to be on the PA, it's going to be on the downside, and the AP is going to be on the upside. But
Sorry, can you explain the upside versus downside thing again?
yeah, downside will be closest to the image receptor. So, like, rotate up. So the intervertebral foramina that's closest to the image receptor would be the downside.
Yeah, and
Okay.
so it's called. Is there a reason it's downside?
Down, as in closer to the
Okay.
image receptor. Yeah,
Okay,
that's just what we've always referred to it. So whatever's furthest away from the image receptor is the upside.
Got it.
Yeah.
Okay.
Yeah. So maybe that all started because they were shooting spine. I don't know.
Sure.
It is what it is.
Yeah.
We've always
roll
done
with
it that way.
Right. Okay.
That thing. Yeah. Okay. So then on the L-spine, again, with lateral, we're going to see the intervertebral foramina, but notice these changed. On the AP, we're going to see the downside. On the PA, we're going to see the upside. Okay. Flexion extension, we already talked about. L5S1, what we talked about. Obliques. Oh, yeah. So this is a fun little exercise. How many of y'all can see the kidneys yet? On a KUB?
Oh.
A few? And I'm getting some kind of hot cold. Okay. So you're going to develop an eye, being able to pick out things. And if you see some oblique L-spine views, and you don't see this, don't get too upset about it. If you can't see the kidneys yet, don't get too upset about it. But how you determine whether or not you've got a good oblique is whether or not you can see the Scotty dog. Okay, so I'll forward to this. That's a Scotty dog. A little scruffy guy with a beard and all that kind of stuff is a Scotty dog. So what we're looking for on an L-spine is that, the projection of that. And it's kind of like looking at the clouds. You lay flat on your back when you're a kid and you look at the clouds and you see figures, right? Figures and shapes. And it's kind of like that. So with a Scotty dog, what we see is the transverse process. That's that thing right there. Get up and magnify. All right. So transverse process. This thing is the nose. Okay. So what we're looking at here is we're looking straight down onto the pedicle. Our zygapophyseal joint is this thing right here. So this is an ear. It's a nose. There's a nose. This nose is kind of going up in the air a little bit more. So we're going to go with this one. Nose, eye, ear. Okay. So then we've got on this vertebra down here, we've got the leg. But look what happens with the ear and the leg of this Scotty dog. All right. You can kind of see that gap right there.
Mm-hmm.
That's your zygapophyseal joint. So zygapophyseal joint is formed by the leg of one of the vertebra above and the ear of the vertebra below. And it's that dark line that we're seeing there. So the rest of the Scotty dog, I won't say is completely irrelevant, but those are the main parts to it, and the way that you determine whether or not you've got good rotation is where is the nose of the Scotty dog? It should be right at the edge of the vertebra. All right, so the further you rotate the patient up, the more that transverse process is going to go behind the vertebra, because in a perfect lateral, it's going to be right at the back of the body, right? So what you want it to be is, and this is critique next year that we're going to talk about this and test on it. So it's not on this test, but just in case you see one of these, the tip of the nose should be right at the edge of the body. That's how you determine whether or not you got a good oblique. Scotty Dog, can you kind of see it? Or are you looking at that saying somebody was on some hardcore drugs? Scotty Dog. I can see it either way. Okay, so it's all that. All that again. All right, so L-spine conditions. So we've got subluxation. We talked about what subluxation is, a sliding of one vertebra onto another. Some of the nastiest L-spine subluxations have been lateral. Used to have a pretty good physical film library that I could pull some of this stuff out. Had one where on the AP, the vertebrae were pretty much sitting beside themselves. Guy was in a side impact T-bone collision, and it completely separated his L-spine side to side. Nasty, nasty fracture. And the fracture is bad enough because even though, again, the spinal cord itself ends at L1 at the cauda equina, you still have those nerves coming off. That guy lost some function, right? He's probably paralyzed from the waist down. I never saw him after actually I never saw him. It wasn't even my patient. I just happened to get a copy of the films. But what is directly in front of the vertebra, again, is, the abdominal aorta and also the inferior vena cava. So I don't know what all happened to that and whether or not the guy had massive internal bleeding, but it just couldn't have been a good outcome for him. Best case scenario was he was paralyzed. Worst case scenario, he just didn't get off the ER table. So spondylolisthesis, I talked about that a second ago. Spondylolisthesis is where you've got L5S1, you've got some subluxation there. And sometimes that's an incidental finding. Patient comes in because they were in a car wreck and now they've got some back pain that they've never felt before. And you take a lateral L-spine and you can actually see that subluxation that the patient's been living with for a long time. So it's non-traumatic. It's just, the patient's anatomy. Then compression fractures, we'll talk about those in the T-spine. That's where the height of the vertebra gets squished. And it can come with some issues as well. So we've got a compression fracture there. This is your spondylolisthesis. This is, anterior alignment the L-spine should come and be pretty well continuous with the anterior alignment of the sacrum, but we've got that subluxation there, and that is your spondylolisthesis. Whether or not this was this patient's particular problem, I don't know. You see on this vertebra right here, you see the way that looks a little bit tubular. Okay, that's what I was talking about before in the non-coplanar, right? That's what you're looking at. You're looking at kind of the bottom side of that vertebra. What you want to see is it nice and blocky looking like that and not having that hollow out looking appearance. Okay. Any questions? And real quickly, we're going to do our SI joints. So what we've got in the SI joint, again, is the patient may have some arthritis set up in their SI joints. So we've got a couple of different things to visualize SI joints. We've got a couple of different angulations. The problem in visualizing them. One is because the iliac bones kind of wrap around the back side of the sacrum, so we can't see the joint itself unless we oblique the patient up, right? So in order to visualize them in any kind of frontal view, it's going to have to be an AP oblique, and we're going to see the elevated side, the upside, right? So what we're going to do is we're going to elevate, and then now look what happens as we just shallow oblique this guy. It's like 20 degrees, 25 degrees. And look at where your elevated ASIS is in relationship to the the SI joint. Can you kind of see how quickly they kind of, yeah, it doesn't take much of an oblique to get them, one, on top of each other, and two, that's where you're going to center, essentially. Just medial to, not as far medial to as what we did on the L-spine, but just medial to the elevated ASIs. Okay, be your obliques. But the other one is because the fusion also has a bit of an angulation on it like this. So we can do another view. It's kind of a AP, it is AP axial, but its intention is to put it perpendicular to those two. Doesn't come with obliquity, it's just an AP axial. That's your Ferguson method. And that's going to be
483.
483. Yes. So it's going to be your AP or PA axial. You can do it with AP or PA, or just got to remember you got to, switch the angulation. So it's going to be a cephalic angulation of 30 to 35 degrees. And your central ray is going to be 1.5 inches superior to the symphysis pubis, which is going to be about 2.5 inches below the ASIs. So stick to my original, recommendation for the symphysis pubis. When you can go with the ASIs, go with the ASIs. There's about a 4-inch difference between the two, so go about halfway in between those, and use that 30 to 35 degree cephalic angulation. Ferguson. I should give you that. Oblique AS or SI joints right there. And again, and I'll say this a lot, full exposure or full disclosure rather, never shot SI joints, not a single time. So chances are you're not going to shoot them either. Sacrum and Coccyx, you might. So they're going to be real similar in their description. The main difference is going to be the degree of angulation and the direction of angulation. So AP axial sacrum, AP axial coccyx. So straight AP, you're positioning on patient, the table is going to be the same. Go ahead and extend the legs though, because the soft tissue is going to cause an artifact. So extend the patient's legs. For the AP sacrum, you're going to angle the central ray 15 degrees cephalic. All right. 15 degrees cephalic, 2 inches superior to the symphysis pubis. Now, what did I just say about the distance between the symphysis pubis and the ASIs?
Middle is
about 4 inches, right? So, you might have a tendency to, look at a patient who's really, really tall and think, well, that distance is, going to be greater. When you see somebody who's really tall, where does that height come from?
No legs.
Legs, in a lot of cases, yeah, you may have somebody who's got really long legs. What's that? Maybe in the torso. How about let's take Shaq for example. Shaq's what, 7'1"? Does he look out of proportion anywhere? Does he look like he's got really long legs? For his body. I mean, he's got long legs, right? But for his body, not really. Does he look like he got a long torso? No. So where's all that come from? Just a little bit in every bone, right? So if he gets half a centimeter on each one of those bones, how many bones you got from your, ankle all the way up to the top of your head?
whole bunch.
In a word, a lot, right? So in his, in his pelvis, is the distance between his symphysis pubis and his ASIS really going to be that significantly more than anybody else's? The answer is no. You ever seen anybody that you looked at and said, wow, that guy's got a big pelvis? If I'd have said, the short the short-legged, the long-waisted, whatever, or long-legged. But really, it's not going to be all that different, right? So it's about a 4.5, tops 5-inch difference between the ASIS and the symphysis pubis, right? So if this is calling for 2 inches above the symphysis pubis,
2 inches below.
2 inches below the ASIS, and you're there, right? So 15 degrees cephalic angulation is 2 inches below the ASIS. And then we get back down to the coccyx, and coccyx is 10-degree caudal angulation. And where is it? Same spot. Same spot, right? So 10-degree caudal angulation for coccyx, 15-degree cephalic angulation for the sacrum, both in the same spot, 2 inches above the 2 inches above the symphysis pubis, which is 2 inches below the ASIS. So we can tell that this is a sacrum because the coccyx is hidden behind the symphysis pubis. We're just not going to see it. And then we can see the coccyx there because we angled caudally. So then we've got lateral, right? In a lot of cases, you're going to shoot a lateral sacrum and coccyx. All right, so if you look on page 492, you'll see a little diagram of exactly how to find your sacrum and coccyx, right? So if you find the ASIS and you go posterior, directly posterior to the ASIS, you're going to find your sacrum. And then if you go 2 inches inferior to that, you're going to find the coccyx. The coccyx is, harder to localize physically than what the sacrum is, for obvious reasons. It's kind of, tucked down in places you don't want to go. So it's going to be harder to find, but if you keep that in mind, you find the ASIS. Notice they kind of clip the sacrum on this one, but if you go directly posterior to the ASIS, you're going to find the sacrum, and 2 inches inferior to that, you're going to find the coccyx. So if you're interested in seeing both sacrum and coccyx, just open the collimator, make sure that you include them both. If you're just looking for the coccyx, then collimate down a little bit more. Okay. Any questions on those? We talked about the lateral bending and scoliosis, but there are a couple of other things that we need to talk about in scoliosis series. And that is that most of the time scoliosis series is going to be young women. It could be young, or not even young women, little girls. Could be little boys as well, but most of the time it affects girls at a greater rate than what it does guys. So a few things on that. One is you got developing breast tissue that you want to protect, right? So we need to take some precautions for that. What they're going to be measuring on a scoliosis series is that primary and secondary curvature and see how much of a curve the patient has. So what we need to see is we need to see the entire spine. So what they might do is one of two things. They may have a single image receptor that's long enough to capture the entire spine. Probably not. With our computer processing, what we can do is we can take separate images of different portions of the spine and use a what they refer to as a stitching program to put them all together to make it look like a single image. Okay, so you're going to shoot a T-spine, maybe to include C-spine, and an L-spine, and then stitch them together to make a single image out of it. We're going to shoot this one, though, at 72 inches, and we're going to shoot a PA. All right, and the purpose for the PA is to use the body as a filter out some of those low energy X-ray photons are just going to absorb inside of the patient's breast tissue anyway. So we're going to shoot PA, and we might also use what they refer to as a trough filter. So a trough filter is kind of like a wedge, and it's a wedge on two sides. So it if this was our patient, the fattest part of the wedge would be out here laterally. And this goes on collimator housing, but it would be out here laterally, and it would act as a different layer of collimation along with some filtration. So it'd be real fat out here on the edge, and then it would get less fat as it comes in. And the purpose for that is because if the scoliosis is pretty great, and even if you position directly in the center of it, you know, if it bends out too far and it overlaps a part of that wedge, you don't want the fat part of the wedge covering the spine, because then you can't measure it, right? So they want the skinny part so that there is a little bit of latitude there, a little bit of, you know, forgiveness in it. So wedge filter, 72 inches, PA projection, and we're always going to do a PA, and we might do a lateral as well. Might include some of those lateral bending as well. If you're doing lateral bending, of course, you're going to have to take the wedge filters off, and it's just going to be, you know, wide open. But lateral bending as well. So most of the time upright. If the patient can't get upright, I had scoliosis patients where the scoliosis was so severe the patient couldn't stand. You know, they were in a wheelchair all the time. So upright if at all possible, but if not, they can do it on the table as well. Okay. And I think that's all I have for you. That's scoliosis. Lateral bending. Notice that, you know, we've got some really good bending in one direction. The opposite direction is just not quite so good. I told you about the Harrington rods last week. You remember talking about those? They latch onto the transverse processes. They just straighten out the scoliosis. Any questions?